may or may not have seen up to this point in PA school is a document from the AAPA. This is also reinforced by PAEA, as NCCPA, and some of the other bodies, including ARC-PA, about PA competencies. And this is something that is going to become more important as you actually become a certified PA. A couple weeks ago, I was lucky enough to go to the NCCPA for a few days for a conference, and I'm learning about more of the new things that are occurring with our profession and some different directions that they're going in. And a lot of this comes back to these core competencies. And that document, when you have some time this weekend, please look at that. The main areas include medical knowledge. That's something that we seem to focus a lot in our didactic here in. But then there's other areas of interprofessional and communication skills, something that seems to be a little more enhanced in our second year of clinical patient care, again, more in the second year compared to first. Professionalism throughout the entire program and your career. And then a systems-based practice, which is involving more with hospital systems and EMRs and different things that you're all going to get involved with. So take advantage of any and all those opportunities when you will be starting your rotations next quarter. All of you guys are broken into groups of 4 right now. Some of you are already in groups of 2, and some of that will be changing a little bit. But basically on Monday or Tuesday, I'm going to be sending or including on the Moodle a document that breaks up the entire class into 4 main groups, groups A, B, C, and D. And on the syllabus, you'll notice for some of the labs, different groups will be coming in at different times. So maybe the first week, Group A comes in, and then 2 weeks later, Group D will come in first, and that. So some of you got, and I balanced it all out, so you all get a little extra time to sleep on certain days throughout that. So that'll be coming out on Monday or Tuesday for you. The surgical ostler. I had some of you guys ask some questions about this last quarter, so I just want to take an extra moment to explain it. The ostler itself will be a 1-hour assessment, very similar to what you've already done, but it will be a little more in depth. And in a few minutes, I'm going to show you a more complete history and physical exam with review of systems, and we'll talk about primary versus secondary assessments. And that's going to all become very important as part of your write-up. The good news is you will be working in groups of 2. So long story short, the group of 4 that you worked on the paper with will be assigning in that group a group of 2 of you. So both of you will be the provider on the patient. You get to work together a little bit during that hour, but it will be more in depth. There will be more things that you'll have to kind of a check-off list. Transfusions is a very important one. The history of transfusions, any types of reactions, documenting those types of things. So we'll go through all of that in just a few minutes. And then there'll be a write-up, a hospital write-up, which will include a full admission H&P. It'll include the hospital operative report that will teach you how to do. It'll also include the discharge summary, as that's something that you should be able to see once, I think, before you actually start your rotations, because you'll all be in a hospital system somewhere, and you'll at least see it. You may not be actually doing or dictating it, or maybe you'll be involved with a portion of it. But you'd be surprised, depending on where you go, they may actually have you do the actual discharge summary and learn the components of it and how to write up the medications and the different plan and follow-up and all that good stuff. So we're going to go through all of that in a couple weeks. And the surgical ostler is not going to be for about 2 months. As I mentioned, it will be in groups of 2, so that'll be a little benefit for you. And then all the topics are on Moodle, which I'd like to show you right now. So if I go to the Moodle system here, I uploaded the ostler surgery list at the very top. So just so there's no confusion as is, oh, it could be 1,000 things that I would get for the ostler, we've narrowed it down to 20. So one of these 20 things, and these are all really topics that you've learned before regarding the appendix, if maybe a patient is going to come into the hospital to get their appendix taken out, or maybe it's a gallbladder issue, or a thyroid nodule, or it needs a thyroidectomy. But it's all the medical issues that we are now applying a surgical treatment for. So this will be a patient that will present, to the hospital, usually preoperative, to get their open heart surgery, or to get their thyroid removed, or to get their joint replacement, knee replacement, or something like that. So we're going to teach you all the components of it, so it's not a surprise. But when it comes to the medical stuff, when it comes to all this that you've learned about, what signs you look for the appendix, or what signs are involved with mesenteric ischemia, or what signs, or whatever the topics are listed here, though that's everything you've learned in your Bates and you've learned in your CAM courses. So that's what your refresher needs to be. So if in your groups or in your class you want to divide up, now, I'd recommend that. You pick a topic or so, and or maybe one group is going to do the complete workup for the appendectomy. And then that group has done that, and another group, there's literally 20 groups in the class. I thought that'd be a great suggestion if you all picked one of them, and then you can share with the others. That way you're not reinventing the wheel with all 20 of them, and maybe you can fine tune it then when you get that from somebody else. So again, the surgical oscillator is not going to be for a little while, but now you can start thinking about this and preparing for it and communicating with other students in your class on maybe if you want to work together to come up with a good plan. Surgical Scrub Saturday. So as you saw in an email before, on October 7th, which is Saturday, we're going to have a full day actual surgical scrub at the Ambulatory Care Center at UT. Your groups, I will also be assigning this week. I already have. I'll upload it on Monday or Tuesday when I include it with the groups. This is not an all-day event. On average, you're going to be there about an hour and a half. So the group of the 4 of you in your group that you've done for your paper will be at this Ambulatory Care Center for about an hour and a half that day. The times will be anywhere between 8 in the morning and 5 in the afternoon. And Professor Lay and I have worked on the schedule for that. So we'll be getting that out to you. I know some of you had some questions about some of the timings with that. And I wanted to also show you on your Moodle site here, later today, when you will be doing your dictation of the actual, or transcription, I should say, of the actual dictation of the surgeon, and it'll most likely be a cholecystectomy patient there. When you type it up, you're going to be using that as a guide. But I've given you another guide here to look at some other operative reports. And we're not going to be worrying right now about the beginning part of the pre-op diagnosis, post-op diagnosis, assistant, estimated blood loss. But what I am going to be focusing on is this part, the actual procedure. And there's about 4 or 5 other procedures right here that you can see, and I ask that you use this as a tool when you're going to apply this for the actual 5-minute video or so on YouTube, and you're going to become the surgeon to dictate. So you don't have to go to lots of different places. I've given you the resources right here for these different dictations. You saw the email, Ken afterwards. Okay, so one of the first documents I've included in your Moodle handout for today is regarding a brief history of surgery. I think it's always good to start out with that. You want to try to log in? Or? Sure. You want to try that? Sure. I can go off the notes here. Please, please. So I'm just going to follow the document here and highlight a few things in particular off the actual document. So you all have received this brief history of surgery PDF there. And just, when you watch some of the old movies, there's a movie I came across a few months back on Netflix called, I believe it's The Physician, and it's really interesting. And if you have some time, look at that movie, probably not this quarter, but if you have a break after this quarter, because it talks about what happens after the Middle Ages, and in England with the barbers and the surgeons, and we're going to talk about that and how it all got started. There was a time in this world where dissections were forbidden, and for a long, long time, for hundreds and hundreds of years. So we didn't understand a lot of the anatomy, or what we thought we understood from animal models, we found out to be wrong 200 or 300 years later. So when you go down this list, you'll see the first word there is trepanation, and this is something that's always perplexed people, because back in Egypt time and years too. Okay. Yeah, I put in the help desk ticket, so maybe Sean will come up. It'll be at 10. The trepanation, for whatever reason, is when people were drilling holes or removing portions of the cranium, probably due to severe pain, or patients were having headaches. They would drill holes, and they thought this was letting out the evil spirits, something that you probably have seen in movies, or you've heard that wording at some point. And then the ancient Greeks is where Hippocrates, around 400 BC, really started to explode with how much scholarly work was being done with medicine, and the medical side of it, not so much the surgeon side of it, but the medical side really started to explode quite a bit with Hippocrates around 400 BC. They started to use instruments. Iron was created at that time for the Greeks and the Romans, and this is something that was helpful when they were doing the lancets to remove some of the abscesses and drainages that patients would have with infections. And then a little bit later on, Galen was a famous surgeon in Roman times. He worked more on dissections, but again, human dissections were forbidden. So they used gladiators and some of the injuries that were occurring at times of not really war, but more of social war with the gladiators, to better understand anatomy at that time. And then the wars started. When the wars started, we've lost a lot of the documentation from Rome and Greeks, and things were lost, they said, for about 200 to 300 years. And we went backwards to medicine, actually, compared to forward. Until around the 1500s. When the 1500s occurred, then Andreas Berzelius was a human anatomist who, at that time, they started to switch over to actually do anatomy on dissections on human beings, which they learned more from. One of those examples would be blood flow in the heart. They thought that there were these septums, which do occur in pediatric patients, and they saw these holes in that, and that's how they thought the blood was going from the right side to the left side. And then years later, with the adults, when they were actually able to do dissections on the heart, they learned that the septums were actually complete, both in the atrium and the ventricle, and blood was actually two different systems. They actually thought there were two total different systems of blood. The arterial blood was one system, and the venous blood was another, and that they never actually connected. But it seems odd, for us today, but going back 500 years or longer, thousands of years, it was a much different gradual progression with knowledge. And then we got into the time of the 17th century with William Harvey. He did more studies with blood flow in animals, and he discovered that there are valves in veins, and was able to connect the arterial and the venous system through capillary beds, something that we never had microscopes. We couldn't see, and it took a lot of study and research to figure that out. The barber surgeons in the mid-1500s, it's funny because the barbers, the red and the white symbol that you see outside of the barber stores, that's where you would go for medical procedures many times. And it wasn't even that long ago, about 100 years ago, that was still common to see. But back in the 1500s, they kind of connected they try to connect more of medicine and surgery with the barbers. The barbers were a group of people who could do lots of small things to help patients. Maybe dislocations they would try to fix. They would be involved more with wound care, and sometimes even some minor procedures here or there. amputations of digits and that. But the surgeons were more of amputees in the wars. They learned how to cauterize if someone was going to lose their arm or leg with an infection. And back in the day, they would literally burn everything. They didn't understand about surgical ligation of vessels here or there. So it was a much different time that you'll see in your readings with this. But eventually the barbers kind of split off from the surgeons, and the surgeons formed a Royal College of Surgeons. And sometimes in your readings, you may come across this, or if you go to conferences, you'll see in Europe, in England, it comes out of London, this Royal College of Surgeons was formed. In the 1800s, a couple hundred years later, anesthesia was discovered. And the first time it was used in 1846 in Massachusetts General Hospital using ether. Basically, they would drip it. If you ever look at the old videos or such, they would have to drip it next to the patient, and the vapor was what was being inhaled at that time. It's not like we had ventilators or we had masks or anything for that. But it did work, and it allowed patients to undergo larger surgeries, very painful procedures that they never could have done before that time. Then we learned more of a second anesthetic, chloroform, which was used a lot by Queen Victoria during her childbirth, and after that it kind of really took off with anesthesia for more procedures nationwide. Many patients who went to hospitals died, and it wasn't that they died of the condition that they came in there from, but they died from infections. And even today, hospitals are not great places to vacation in. You know, we want to get patients in and out of the hospital as soon as we can, because we know the longer that patients are there, there's a slight increased risk of infections, and that's something we want to try to minimize as best as we can. So there was one surgeon, Joseph Lister, who really took this on, and Louis Pasteur, a couple years prior, understood microorganisms, and they started to be able to see some of the smaller things, not real small, but they learned that there were bacteria and fungi out there. Those are some of the larger molecules of organisms that cause infections. And then this surgeon, Joseph Lister, really started to become innovative, and in his operations, he would try to treat the entire operating room suite with a type of acid, and he would include some of this acid on the dressings for his patients. It wasn't just a simple procedure, and a lot of the nursing staff, there's articles about how daunting this was, and many people thought it was voodoo magic and said there's no science to it. Well, interestingly, his patients ended up doing better with all the research, evidence-based medicine of his patients compared to other surgeons. They said, wait a minute, there must be something, and that took decades to kind of figure out over time. So it's kind of neat that all of that occurred before the time of antibiotics, which literally happens at least about 50 years later, almost 100 years later. In the early 1900s, about 1895, is when x-rays were discovered. You probably heard about that in your radiology course, and that helped a lot because at World War I in the early 1900s, they were able to identify when patients had bullets stuck in them and kind of help the surgeons remove it without having to go in blindly and investigate what was going on with those patients in war. Blood transfusions. You know, there's some interesting things that occurred many, many hundreds of thousands of years ago with blood transfusions, and it was kind of by dumb luck where they would hook up a mother to a child or a child to a father, and if it happened, they didn't understand why. They just understood that 90% of the time when they did this, patients died. But for the rare 5% or so of patients, it did seem to work, but they never understood why. And then hundreds of years later, in the early 1900s, Karl Landsteiner basically discovered the 4 blood types, A, O, B, and AB. And with that, we understood more about antigens and antibodies, and we started to type patients. And then it made sense why maybe the father and the child's blood matched up, but the mother didn't, and they would have caused a transfusion reaction back in the day. So it took a little while to form blood banks and get us all to donate when we can, and now we're able to stockpile blood, platelets, fresh frozen plasma, and in the Second World War, it really saved a lot of lives that it was not able to do in the First World War because we didn't have that technology at that time. Antibiotics. It always amazes me that antibiotics have really only been out since 1935, 1940-ish. I mean, if your grandparents or parents, depending on their age right now, are over about 70 years of age, there were no antibiotics at that time when they were born. I mean, that really blows my mind. You're going to be, it'd be almost interesting to see how many antibiotics each of you use in your year of clinical practice as a student here. And I'm guessing the number will easily be about 1,000 between surgical patients, hospital, ER. You know, it's a lot, but 100 years ago we didn't have any antibiotics at all. And I may have mentioned this story of how it was discovered. It was discovered by accident. In about 1928, there was a scientist, a physician, who was going on a 2-week vacation to Scotland, and he was doing some of his plates, his sheep blood agar plates with staph and strep. They understood that at the time. And he did not want to put them in the incubator because he knew he was going to be gone for 2 weeks. So rather, he decided to leave them out in air, let air incubate it. The mistake he made was he forgot to cover the plates. So when he came back 2 weeks later, yes, he saw the staph and the strep grow out on the sheep blood agar plates, but he saw something else. He saw that the mold, the fungus that's in the air, actually landed on those plates. And where it landed, yes, it grew, but more importantly, there was a zone of inhibition where there were no bacteria at all around that fungus. So the light bulb went off in his mind at that time that this fungus must be producing something to kill the staph and the strep. And at that time, that mold had a name, which it still does today, called penicillium. So he named it penicillin, that it must be making. That's great if you discover it. The problem is it then took another 10, 15 years to actually mass produce enough. They made some mold juice, and then they were able to create it and mass produce it. So it took a good decade after the fact of figuring out what it was, which often happens in research. But nonetheless, antibiotics were discovered, and in World War II, and again made a bigger difference to help some of the patients, and they were able to get some of that overseas, and you're going to use quite a bit of that in your hospital and clinical practice. And that was the early 1900s, 1940s, World War II time after that. And then in the 60s, the late 60s, one of the amazing things happened of doing the first heart transplant. The heart was the one organ that in many cultures you just never touched. It was the soul of the body. They could sometimes do some repairs on the surface of the heart in the early 40s and 50s. And the heart-lung machine was not created until Gibbon in Philadelphia in basically the 60s. But this technology of immunosuppression or drugs to stop the reaction that would occur really wasn't that developed or being used nationwide. So it was amazing when in 1967 in a South African hospital that Dr. Christian Barnard, the story goes like this, and I'm sure you can learn more about it when you go online if you're interested, but a young lady got hit by a truck or some sort of an accident, and she was basically brain dead at the time, and he had a patient who was dying of heart failure, and it just by happenstance happened that the family was willing to give up her heart to help this other patient. And first time ever it was done, and it was a success. It was a success because the patient actually lived. Now, he didn't live very long. He died of a complication. You'll learn about lots of complications like pneumonia and urinary tract infections and sepsis and other issues. But he lived for about a week or two. A couple weeks later, 18 days, it says he died of pneumonia. So that was the first time it happened. And very shortly after that, a few of the institutions in Texas here and around the country, in Utah and Philadelphia, started to experiment more and get that going. The heart is the one organ that seems to trump everything. And I just talked to a neurosurgical PA about a week and a half ago, and he was telling me some stories too where, you know, they had a patient with a brain tumor, and long story short, they couldn't do the brain surgery on them because they had too many risk factors and they weren't strong enough. And that's the one thing that every surgeon thinks about is will this patient be able to get off the table? The worst thing that could occur is that the patient would have a different event, maybe a myocardial infarction or ischemia on the table itself if they're undergoing a gallbladder surgery or appendix or whatever it is. So testing screening is done on all patients, and if they need their heart tuned before they get their other surgery, that's what we do. We'll take them to the OR if it's massive to do CABG surgery. We'll take them to the cath lab to do stents to stabilize them for a couple days. The problem is, and you get into all the anticoagulants and all the other issues, so sometimes you can delay care a little bit there. And then in the early 80s is when technology started to advance, and computer chips were being incorporated into lots of different things. I always think of the Atari 2600, which kind of ruled the world of the early 1980s. And those little computer chips then started to go into other machines. And one of the machines in the operating room is the laparoscope. Laparoscope before that time was a one person kind of looking in through a little lens, almost like a microscope through a tunnel to see it. It didn't have the technology to hook it up to a television. And then when the computer chips started to come out, technology in the early 80s allowed us to use that one-handed scope that surgeons were trying to do through smaller incisions to now allow everybody in the operating room to see, the assistant, the anesthesiologist, the circulating nurses, so they can understand what was going on in the operation, which improved communication quite a bit. And then finally, robotic surgery. The robot, the Da Vinci, is the main one that you're going to hear about, and you may see in some of your rotations. They have some of the surgeons, like urologists, have really expanded their practice by doing smaller incisions and not doing the large open ones. If you have an aunt or parent or grandparent, whoever needed their gallbladder out 30, 40, 50 years ago, and you'll see they have this big scar there. Or when we would do lung surgery, you have the posterior thoracotomy, which spreads the patient wide open, these big incisions, and they're extremely painful. But you will see them in patients, especially if they're in their 60, 70, 80 years of age, when you're doing your assessments in the hospital. Well, now times have changed, and with these laparoscopes and newer instruments and these robots, Da Vinci, the surgeon is no longer at the operating room table. They're in the operating room, but they're not in the table. They are in a corner and in a machine. It's like they're playing a 3D video game, and they're using their hands, they're using their feet. They're well, you'll see definitely when the OR there. So they are totally removed, and that's where we as PAs in the operating room are becoming more involved, because somebody does have to be next to the patient, switching out the instruments that the surgeon is going to be using there. It's not like they have 40 different instruments that can come in with this. You have to exchange different things and help the operation. And I have a few friends that are ORPAs that do a lot with the Da Vinci Code, and it's a little bit different. So hopefully you might see that at some of the centers across the country. The next thing I want to talk to you about for a little bit here is common religious practices, and basically what impact it has as you as a PA student who takes care of patients with different backgrounds. This was something that I never had when I was in PA school, but I can tell you, working at Mayo Clinic and other hospitals, you see people travel from around the world to get different operations or medical care. And what we do here might be very different compared to what they do overseas, whether it's their cultures or that. So there's a nice little article I came across that I am going to ask you to look at this weekend. And I just want to highlight a few things on this list and then share a couple experiences that I've seen with patients in the hospital who come in. Buddhism often focuses on this term mindfulness, and medications that we use for patients that sometimes clouds the mind can have a big impact for these patients, and that's something that we have to consider, where they may be willing to turn down some pain medications, narcotics that I've seen. They often prefer quiet spaces, and we often have different wards. We did at Mayo Clinic for different patients and different prayer services and different areas that they could meditate in. Many of them, not all of them, are strict vegetarians, and that's something that may be important when you're writing diets in your plan. Switching over to the Catholic religion, Catholics believe heavily on the sacraments. There are 7 sacraments, and baptism is the first sacrament, and the last sacrament is basically anointing of the sick when you're on your deathbed. And this could be something that patients who are really devoted to the Catholic religion may call for a priest to come in for that last sacrament, that last rite, as it's called. So you may see that, and sometimes someone's going in for a big pancreatic Whipple procedure that the night before, you as the PA have to coordinate with pastoral care, maybe have to coordinate with the priest in the community there, and they will come in many times, especially if it's their parishioner for that. The Hindu patients, modesty issues that you'll read about there, as well as vegetarianism. What I've noticed at Mayo sometimes is if a patient does expire for whatever reason, they have more rituals related at the time of death. And that's something that many times you'll have interpreters in the bigger hospitals, and culturally they're very involved with this, and they'll have different staffs of people to help the family members at that time. Jehovah's Witness patients, the biggest thing you'll see here is they have a very strict prohibition of receiving blood or blood products. And this can be problematic when you have patients undergoing big operations. Cardiac surgery is one of those examples. Usually, I would say, on average, patients undergoing open heart surgery in the operating room, not post-operatively, are receiving probably 2 to 4 units of blood. It's not uncommon for that. And these patients, they forbid it. It's against their religion. So I've seen before that their bishop or so comes with the patient literally up to the operating room and makes sure that they will not receive any products, and they are willing to die for that, which is something that you have to have a communication with, and it has to be well all discussed. I was telling somebody last week that I'll never forget the first Jehovah's Witness patient we did in the operating room, and the surgeon said, every tiny drop of blood, we used to do what I call filet-o-leg, where you just take the scalp and you open up the whole leg to take the vein out that way. And he said every tiny little drop that you see, Bovie, and you just make sure they don't bleed. And it was amazing to me because at the end of that operation, that patient's hemoglobin was 14. Most of the time, we're walking out of the OR with a hemoglobin of like 8 to 10, which is pretty normal. And it usually goes down after that because they get more fluids in the ICU, crystalloid, which ends up diluting out the hemoglobin more than anything. But nonetheless, when you say, if you can start out with a higher number like patients do there, and like 14, they just do great. It made me wonder then, why don't we do every operation like that? Yes, it tacks on an additional probably 45 minutes to an hour, but it seems to be the right thing to do. Jewish patients, some of them are very strict regarding the Sabbath, which is the sundown of Friday to the sundown of Saturday, where they do no work. And that no work, I've learned through the years, can include things like turning on a light switch. That is considered work. So different hospitals in New York City or different areas, there's different levels of it, and work could even be defined by some as tearing off toilet paper, where they have to have individual sheets of toilet paper for the patients. These are things that you may encounter, and it was kind of surprising. The first time, I'm from New York, but the other end of New York, Buffalo, New York, and at a conference once, I met a Jewish man from New York City area, and he taught me that he cannot even write any material from Friday to Saturday at that time until sundown on Saturday, because writing is considered work. He can sit, he can listen to lectures, but he was unable to write that. And he actually came up to me and just explained it beforehand. So you may see this in different patients, and it's good to just be aware of that. Muslim patients, modesty, sometimes they have different prayer rituals as well. The one thing that I have seen, and it was kind of a big surprise, is sometimes different cultures, some cultures don't ingest any pork, like often some Jewish and Muslims, as well as Hindus, they hold in high esteem cows. They're not going to really be eating them, and different things there. You have to sometimes think about that with the diets in the hospitals, because if you don't specifically spell it out, that could be an issue. The one issue I saw in Mayo that I'll never forget, it was like, oh my gosh, I can't believe this just happened, and I wasn't expecting it at all, was a patient came in from overseas, a Muslim patient, and complicated heart surgery. We tuned them up as we do, and a day or two later, we were on the floor. The patient was transferred from the ICU, and they ended up getting a valve as well, a tissue valve. And the translator was in the room, and they were asking some questions of the surgeon about the operation. And the patient asked, what kind of valve did I get? And there's a pig valve or there's a cow valve. And the surgeon said, the pig valve. And I saw the translator, and she did not want to translate that to the patient, I was like, ooh, one of those things. Sometimes you don't think about that, right? And everything was okay. He was happy to be alive at that moment, and life was good, but that could be sometimes an issue. And communication beforehand might minimize some of that. Pentecostal patients, sometimes they pray very loudly, and having different areas in the hospital, which we sometimes do. You may see that some of them believe more in miraculous healing from time to time. So there's different cultures regarding all of that to know about. The more complete history physical exam I want to review now on your Moodle site here. So what I try to do to help you with your surgical oscillor is put it all down in one area as more of a checklist for you to study, and 90% of this you already know. But a few things to go through a little more in depth will be obviously your introduction as a PA student, being properly dressed with your name tag, understanding the identification of the patient, which now includes their gender and their age for the setting that you're in, and we're going to give that to you. If it's a patient presenting to the ER, that they're going to need to be admitted for this operation the next day, or maybe they're coming in for the preoperative evaluation with anesthesia. You are going to be the hospital PA, basically, who's going to be evaluating these patients. And the mindset that you're going to have in doing this oscillor is they're coming into the hospital for an operation, and what do you need to do for the full history and physical exam to get the orders set up and everything you need to discuss. Medical providers, this is something that we haven't really stressed much at this point that I've heard, but coordinating with their physicians or other medical providers is going to be very important. And to include those names on the admission notes, on the discharge summary, so those providers also get a copy of the discharge summary. Communication is most important, and if anything that we can do to help that is something we as PAs should think about earlier on. So this little checkbox of asking them who are their medical providers, and if they have a contact or where it is something I'm going to ask all of you to do at that time. Chief complaint, is in quotes, and it's really two parts. It's not just headache, but there's a time associated with that. So just to be clear, it's the problem in their words. We don't change it at all. It's specifically what they say, times however long it is. 1 day, 1 hour, a week, 1 month, etc. The HPI, I've spelled out a little bit more. I feel that most of you guys do about 98% of these, but sometimes a couple of these get missed a little bit. So take some time, look at your Bates book, look at your history and physical exam book, and use this as a checklist of different things to ask about. Previous treatments, have they had this before? What have they had done for this? Maybe they've had another operation for it in the past, and they forgot about it because it's been like 30 years. So that's something I'm going to want you all to ask. Allergies. There's really 4 main categories that I think about as a PA that I want you guys to stress as well. Not only medication allergies, which is something we already know, but then there's food allergies or environmental allergies. That could become an issue in the hospital with different foods. Adhesive tape and latex. Another 2 little check boxes that's important, especially in the operating room. We want to know that earlier on. Latex as well. Medications. When you're going to be writing out your medications here, there's a specific way you should be writing out not only the name of the medication, the generic name, that you always write out the generic name and maybe put the brand name in parentheses after it, but you must remember to write it out as generic name. And a lot of hospitals are stating that to get away from the trade names. NCCPA also for your board questions. Just so you know, they have confirmed that they are in the process of going to 100% generic names only. So you may call the drug Strattera each and every day when you're in practice, that's fine, but you need to know for the boards and for hospitals, tamoxifen is the real name, the Strattera generic name, and be able to document that way. So the dosage of it, SIG is how often that they're taking it, the reason for taking it. That's something else that sometimes we overlook, because you can take Coumadin for literally 20 different things. And understanding, oh, this is for AFib, or this is for DVT, or whatever it is very helpful. So the more information, and that's something that's part of your checklist you'll need to do. And then if they've ever had any adverse effects and what they are of those medications. Not just prescription medications, but we should harp on more of the over-the-counters and herbals as well. Today, patients are using more and more over-the-counters. Medical history, you've done all of this, your childhood illnesses, adult illnesses, any trauma. Sometimes we lump trauma with hospitalizations or injuries, that's fine, but try to have that as a checklist. Have you had any trauma in the past? They may or may not need a treatment for it, but it's important to ask. Injuries, hospitalizations, and be a little more specific with the hospitalizations of when did it occur, as best as they can tell you what year, what was it for, the name of the hospital. That's really big. Remember the surgeon's name or someone else, that's great, but having the hospital name, the reason of the year, or any complications is important there. And then your immunizations. Surgery history, I've kind of broken away from the medical history, and you're going to focus on their surgeries in their past, including, again, the year, the name of the surgeon, if possible, the hospital, any complications of it. Transfusions, that's going to become important. We're going to need to know that more so in the hospital. As a good PA hospitalist, it's one of those checklist things. Organ donor status. That might be important to know. It may be on their license, it may not be on their license, but if you don't ask the question, you'll never know. So ask about it, document it in the chart, and then if ever needed, you can look it up. Family history, the first degree relatives, the age of the patient, are they living, are they deceased, what did they die from, their general state of health, and then any extended family medical problems. So this is where we get into any genetic issues, maybe in the cousins or grandparents. It's a little more removed from you. Social history. So I'll give you an example. I was just thinking about it. My wife, her grandfather was in the war and was suspected to have the Creutzfeldt-Jakob disease. Not confirmed, but if you look at the guidelines, 2 generations out, they're not supposed to donate blood. So unless they undergo the testing to confirm that they are negative for it. So that might be something, any extended grandparents or cousins that you want to think about. Social history, there's a few new things here. Your smoking, your alcohol, how much, your drugs, marital status, religion. We just kind of went through some religion things that might become important. Jehovah's Witness with blood transfusions, very important to know there. Your diet, exercise, nutrition, sleep, stress, caffeine, occupation, all of this that you've done. Travel, I just want to say a quick thing on this at the moment. recent and remote travel. You know, sometimes people don't think of travel unless they've gone to Africa or something, but it's good to know. I always say, have you done any traveling? I say in the past 3 months, and then I try to say in the past 3 years, because you just never know. Maybe they were in England at that time, and mad cow disease occurred, and now they can't donate blood or so. So I kind of, in my mind, always say any travel in the last 3 months, more recent. That could even be like malaria. That helps you in your medical practice, because sometimes people have issues, and it takes a while for it to actually fester. So 3 months and 3 years, I just want to say that. Sexual history, preference, orientation, number of partners, satisfaction with it, any problems that they have, their LMP, could they possibly be pregnant? You know, people are becoming pregnant a lot earlier and a lot later in life. Birth control, do they have any concerns for STDs, STIs? And then your screening tests, your eye exams, dental, colonoscopies, mammography, Paps, pelvics. And the next thing we're going to review the United States Preventive Task Force guidelines also. I've tried to, maybe this will help you in your clinical practice as well, give you a more complete review of systems. And I always say, when it's a specific problem, so if it was just a heart problem that they're coming in on, not only are you going to be checking the heart, but one system above and one system below, like the pulmonary and the GI system, but you're going to want to ask more questions. It's not just going to be a checklist of, oh, I need 2 from this box and 2 from this box and 2 from this box. So I wanted to give you as many as I can think of, but if you guys think of something else to add to this list, please let me know, and we can always improve it there. But I try to, in my mind, think if it's a GI problem, 10. 10 is the number. If you're a specialist working in GI, on your review of systems, what are the things you want? Do you just want to say 2 things? They just have nausea, vomiting? No. I would try to pick a bigger number of 10. And that's, so if you go into GI, you're going to focus more on maybe that's all the issues you want to ask about or deny or confirm what the patient has for all of these. So please look at this over the weekend, and if you see any additional ones, shoot me an email, and greatly appreciate it. After you get that, obviously you're going to state you're going to wash your hands, and actually wash your hands in the room. Your physical exam findings are going to be a little more extensive, not only with the temperature and some numbers that will give you, like the pain that the patient will tell you that they have, but now, because you're working in a group of 2, you will be doing the vital signs on that patient. You will be getting the blood pressure, you will be getting the heart rate, and then you'll be tested to see how close you are to the actual numbers. So it's kind of a confirmation of that. Your pulse ox, your height, your weight, and then you'll have to calculate the BMI for the patient with the numbers there. So you'll have that team of 2 to help you divide and conquer how you're going to do all this. Your physical exam, everything that you've already learned in Bates, all your standard things that you'll do as needed for the patient. And then when you're done with your physical exam, we're going to ask you your differential diagnosis at that time before any labs. Your thought process is what's important, and your labs or diagnostics are supposed to either confirm or deny what your suspicions are. We're not really supposed to just do the shotgun thing of all these labs to hopefully figure out what it is. But you may know that the patient says they're coming in for this for an operation, or maybe not. So maybe the physical exam findings, maybe the review of systems, maybe something else is going to now show you a different direction. So that's all the information you have to put together. And we're going to have you write down your list of differential diagnoses at that time, what you think it most likely is, number 1, and you kind of go down the list. And then after that, you're going to ask about your labs and diagnostics, and we'll try to include more. We'll try to include radiographs, maybe CT scan, maybe MRI. You had a radiology course, so let's incorporate some of that there. There's going to be an EKG on every single patient. There's going to be labs on every single patient that you'll need to interpret. Your standard labs that I made you memorize, in like your Chem 7 and your CBCs, those are going to be normal without reference ranges. All of the other labs will give you your reference ranges for ALT and lipase and all that. But your standard Chem 7, your CMP, and your CBC that I've said many, many times, you're not going to have reference ranges for that. It's pretty standard for potassium and sodium otherwise. And then after you get all of that information, we're going to have you write down the assessment. And the assessment, I know I've talked to a few of you with ostlers in the past with this. The assessment is divided into primary and secondary assessments. The primary assessment is your main diagnosis. What are they really here for? Maybe it's rotator cuff tear. Now they're going to need a surgery for that. That's the main problem. Your secondary diagnosis is everything else the patient has. So when you go back up on your review of systems or your physical exam or your labs or your vital signs, any abnormality is an assessment. Maybe it's hyperglycemia that you found as well. Maybe it's significant family history of coronary artery disease. That's an assessment. Maybe it's hyperlipidemia if the labs show that. Maybe it's hematuria if they have some bleeding going on as well. So maybe it's history of status post cholecystectomy in 1983. Anything that you have found with that patient, doesn't matter how small it is technically assessment. And I'd rather you learn to do more now, and then you can always kind of fine tune it when you work in specialties here or there. But this is one time that all you have to do is when you're going through your history and physical, and you circle any abnormality. And all you have to do is you go back, you're literally listing all the circles. That's all it is. Any positive that you find at all. And then you're going to have an oral presentation. You're going to have to present as if a summary of this patient, just like you'll do in the hospital at that time. Of, this is a 43-year-old male who's presenting for rotator cuff surgery planned for tomorrow. Symptoms started out blah, blah, blah 6 months ago, and on physical exam, he also has some positive findings of this and this. Labs show significant, labs are normal other than the potassium of 4.2 or higher number, of course, 6.1 or 2.8 or something like that. So you're just going to do a brief, probably a 2-minute summary of that patient to get in the habit of presenting. That's something you're going to be doing a lot in primary care, in hospital medicine, in the operating room. That's how you package it. They need to understand that you can take this information and package it into a 2-minute summary of what they really need to know. Now, do they really need to know that their grandmother had, it's not a list. You're not going through all the secondary assessments of the patient, but you're summarizing what's most important at that time. And then we'll be giving each group, a couple questions regarding that topic. So maybe, let's say it was a knee replacement that the patient's coming in. Maybe we'll ask you an anatomy question or something to correlate what you've done there, all of which will be everything that you've kind of talked about in the past. The United States Preventative Task Force, and then we'll take a little break here. So there's a guideline sheet I put together. It's much bigger than this, but I only cut and paste probably 30% of this entire document for what you need to know, I feel, as a PA who's going to be going into surgery or hospital medicine or primary care. So United States Preventative Task Force has come up with some guidelines that you may or may not have heard throughout your CAM series. And this is, as you saw, one of the check boxes under the complete history and physical exam that you're going to be doing for the ostler of the patient. So maybe, like it's this first one, it's abdominal aortic aneurysm screening. So a patient 65 to 75 years of age, you need to know that there is a recommendation for a one-time ultrasound in men age 65 to 75 who have ever smoked, either current smokers or in the past. So that's going to become important to talk about. It's a hospital PA. Maybe you may or may not do it right before the operation, but you're going to talk about it, you're going to document it, and at least it'll be a reminder at the time of discharge that you have to do it. So that checkbox of the United States Preventative Task Force, this is the stuff that I need you to go through, and most of this you probably have already covered in different areas. A couple things to point out on this. Obviously, depression screening when needed, folic acid in women who are planning to become pregnant, hepatitis B virus for high-risk individuals, and C, one-time screening in any adults born between 1945 and 1965. So you may work with a family practitioner in your rotations coming up who is really keen about this one United States Preventative Task Force and wants to make sure that all of his patients or her patients are going to be screened if they were born between 45 and 65. but understanding these guidelines, or at least hearing them one time, will be very important. This is another one that I've seen in primary care, that with HIV is can be done in 15 to 65 years of age. A screen can be done at one time. TB screening, lung screening. This is another one that you may never have heard of, that they recommend annual screening for lung cancer with low-dose CT in adults 55 to 80 years of age who have a 30-pack-year history of smoking and currently smoke or have quit within the last 15 years. That's a pretty important guideline for us to know in medicine. And I'll be honest, I didn't know about this until my doctorate program when the pulmonologist was doing the webinar on it one day. And I'm like, oh, so he made us all go to the website and kind of look it up, and then the light bulb goes off. And I'm like, oh, that's kind of new. And it is. It's a, the categories are A, B, and C, and it's a B, so it is recommended there. Obesity, statin use, tobacco, and vitamin supplementation, use of beta-carotene or vitamin E. And interestingly, they recommend, because of evidence-based medicine, many years ago people were using quite a lot of vitamin E, and it worked against the statins and ended up having higher morbidity and mortalities. So beta-carotene and vitamin E is not recommended for cancer or cardiovascular disease there. So let's look at that as well. And it is now 11:10. Why don't we take a 15-minute break, come back at 9:25. 9:25.
I need to run home and get.
Don't mind your way.
Sorry.
Is it the one that you said that we use? It doesn't look like when you think,
Yeah. Congratulations on this whole side of the classroom.
Billy, Nick. Billy, when I went to San Diego, I got us some cigars.
Congratulations, sir. I thought about hey, look, Spencer's there. Hey, Spencer. Hey, Spencer's on the side. I thought about sitting somewhere different today. For a half second. I would be surprised. And then I'd say,
Better you than me, bro.
oh, I told her. I said, nah, but I have zero money. At least another 5 years. At least.
She went from did not care. Yeah. To like, I've already been out. I'm one lecture already. Yeah. She's like,
Two, that was.
I'm just gonna crank up the radio. Get out of here.
And I'm right, like,
Just gonna crank up the radio.
We had a ball we had. That's exactly what I thought.
I was in bed.
Yeah.
His keys in the trash.
What?
The first week.
Who's doing the game? Anybody know the game?
Yeah, me and mine are working.
How does it work? Like, have you done a game already? Okay. Do I need to do anything beforehand?
Yeah. Just wear white shirts and black shorts or.
Khakis? Yeah.
Don't work out there as well.
No.
White polo, black or navy.
Okay.
Or shorts.
That's what I was thinking. It's like, sorry, you yelled out.
I just wear black. You'll get a name tag there. Tier hours or something.
I think so. I didn't see his car last night too. And I saw his car that I was like,
Yeah.
didn't show up. Skylar was there.
Damn shoot.
Yeah, watch it. Whenever they said it, I was like, I bet.
I had to put my money on it.
And then somebody else was like,
Stoop?
they said Stone. And I was just like, boy.
What offense I let them know ahead of time.
They're pissed at everything.
They take their shit seriously.
They too seriously. It makes me mad. Like,
Did you leave early last time? I'm not like early, but like you didn't stick around for like the debriefing at the end, right?
I did.
You did?
Yep.
I didn't see you for like ever, so I just assumed you were gone.
No, it was me and,
So Liz and I was bailed. We was like,
did y'all check out? Alright.
we were just like, hey, we brought all this stuff down, like we're chilling that first like first aid station, and we're just like,
Did y'all go?
why aren't we doing anything? So, yeah, we were,
I'm excited to have a good dog. I'm excited to have a dog. Like, if we end up playing together, because, like, oh, really? If they're like, if they're in the same pool. That's cool. That's what I'm all about. All about that. Because I had a dog. I was just like the good dog, like, and then every other dog is
I feel like she's such an awesome dog that every single dog is gonna be never gonna be here. I would so
bar too high.
I didn't say that. I was like,
Don't say, you know, they're maintain that. So to me, that's it. Purgatory.
There is like yep.
Trying to deflect it, I'll stab your hand. This is a World War
You were like, I'm in the right fucking place. Give that content. I mean,
Hey, what were you talking about?
yeah, I don't know. What's the You'll find your way back up there.
Anything there, I just show up and process and stuff. Did you bring that sheet for the hours?
Well, I didn't even check that. I doubt it. I doubt it, though. I highly doubt it.
It's so small.
We all picked up.
I was going to watch the game.
Okay, welcome back, everyone.
What time? Yeah, well, I'll save some buffalo chicken there for you. Yeah. Hey, what are you doing Saturday? Are you working it? Yeah.
For the last 30 minutes of the didactic section here, I thought what I would do is summarize a little bit of the first 4 chapters. As you will see, on Monday morning, you'll have a quiz that will include the first 4 chapters of reading. And more than half of that, probably 70% of that, is stuff you have heard already in your emergency medicine class, or nutrition class, or hematology that I've taught. Chapter 2 is hemostasis and coagulation. But nonetheless, I think it would be good to just highlight a few little things here and there, so you can see the big picture. Now, I'm not saying that questions are only going to come from my slides, so just be clear about that. But I feel this might be a good way to see the big picture and to help answer some of those objectives that you'll be reviewing later on. So when it comes to wound healing, which is the first section in your chapter number 1, the way I mainly think of this is dividing it up into 3 categories and 3 phases of wound healing. When you talk about the categories of how wounds are going to heal, we as providers can either decide to close the wound with primary intention, secondary intention, or tertiary intention. And maybe you've covered this in your emergency medicine or not. And primary intention is what we want to do within the first few hours to close it up. That's going to be a lot. You're going to do a ton of interrupteds in your emergency medicine rotation when people come in with blacks. Here or there, they're clean wounds for the most part. Maybe the kitchen knife gets them, maybe something in the workshop area. So we'll talk about timing in a few moments, but primary intention, clean cut wounds there. Secondary intention, we want this to heal from the inside out. So we're not going to be closing this. Okay, we want it to heal. It's usually often dirty wounds, maybe an abscess or some other kind of contaminated wound. So we're not closing it. You're allowing it to close from the inside out. It's kind of an interesting concept when you're going to see this in the hospital. You're like, what do you mean? Why can't we just, take them to the OR and cut a bigger chunk out, clean it up, and sometimes we do that as well. But you will see secondary intention done. And then tertiary intention is just that, where you allow some of the healing to occur naturally. And then you take them to the OR, you debride the area, and then you will suture it closed altogether. So in surgery, you'll see that. It's well described in your book, the three areas. When you talk about the phases, there are 3 wound healing phases. And if you were to cut yourself right now, the first phase that would occur is called the inflammatory phase. And basically hemostasis, and I think I have this in the next slide here to give you a little bit more of each of these. Hemostasis is the main thing I think about. It wants to stop bleeding. If you cut yourself, what is going to happen for it to stop bleeding initially? Well, vasoconstriction occurs. One of the first things that happens is the body will try to stop blood flow to being leaked out of that cut. So vasoconstriction occurs, and then the platelets get aggregated, get pulled into the area, and all the von Willebrand's factor and stuff that we've talked about in hematology comes for it to form that platelet plug. It is also stimulated by thromboxane A2. So platelet aggregation is stimulated by that. And what do you think that might be inhibited by? Common medication that we give, aspirin, right? So that's going to be inhibited. It stops that thromboxane A2. Important concept there to know. And after that initial phase of hemostasis occurs with the platelets and the vasoconstriction, then you get a little bit of vasodilatation. The reason you get vasodilatation is to get more of the inflammatory cells to that area. You want to get more of the neutrophils, you want to get more of the macrophages, so that's why you get a little bit of the vasodilatation. The proliferative phase includes these components of the granulation, tissue formation, neovascularization, where new blood vessels are going to be formed, re-epithelialization of it, extracellular cellular matrix production. You'll see in the book they abbreviate that eventually as ECM or EMP, one of those. The biggest thing I think about are the fibroblasts that are now going to be coming in this second phase that form collagen. And they start to lay down this protein collagen that is very disorganized in the beginning, but over time, more in the tertiary phase, will become more organized. Angiogenesis is going to occur. New vessels are going to be growing, and there's a whole bunch of factors. 2 of the ones that you probably have read about in different areas, IGF-1, as well as the VEGF. So IGF is the insulin-like growth factor 1, and VEGF is the vascular endothelial growth factor. Those are 2 important ones to be aware of. The third phase is this maturation phase. It's the remodeling process. Think of this as it's organizing all the collagen that was laid down by the fibroblasts in the second part. And it takes time. Wounds don't just heal in 7 days as we often think, but it really takes quite a bit of time. And the studies show that the breaking strength of the wound is about 80%, not even 100%, but 80% of its uninjured counterpart by 3 months after the wound first occurred. So 3 months, you're about 80% strength of that wound. When you have broken bones, like when we do open heart surgery and we crack the sternum in half, and yes, we have wires that are holding it together, that bone itself really can take a year to heal. And if you got a golfer, someone who's swinging really hard, they start to get this click. I have a cousin who has that now. He underwent open heart surgery a few years back, and he's got a little bit of a click because the bone never fully healed. And he got out there golfing too soon, I think. He got out about 5 months out, and I would have told him a year, but nonetheless, that sometimes can happen. But he doesn't have any issues from that. Impaired wound healing. You've been through this in many different areas, and I've talked to you about this in the past also. There are some, I think of it as systemic factors. Diabetes by far is the #1. Tissue hypoxia, which is related to diabetes as well. There's a lower amount of oxygen in the tissues, but other things like smoking is a big issue with lower amounts of oxygen in the tissue, and we need that for healing. And nutrition. You know, the factors you learned about in nutrition course, your albumin and your pre-albumin. Your pre-albumin has a much shorter half-life. It's a better test to do, but you can do albumin as well to generally check a patient's status there. Other nutrients, things like vitamin C, very important with healing, and vitamin A sometimes in steroid patients, and there's a whole bunch of little things you'll read about in your book there. Local factors, you think about maybe it's immobility, patients that have decubitus ulcers because they're sitting in their nursing home bed or they're in a wheelchair and they're not moving around as much, that blood flow to that area is more likely to cause poor wounds or cause new ischemic areas, ulcerations, and bacteria to grow up. Some patients have chronic infections for whatever reasons. Maybe it's a fungal infection that they have from out west, coccidioidomycosis or something that's inside them for life, or some of these other infections. Sometimes people have a low-grade bacterial infection in different areas of their body, but it's kind of well walled off, but then that sometimes when it starts to grow more so. Radiation, we don't think about it, different areas of the country. Chernobyl many years ago overseas showed us that radiation really impairs the wound healing. So if we can at least maximize the nutrition, the preventing hypoxia, controlling diabetes, and some of these other factors, then sometimes it will help their wounds overall. Hypertrophic scars and keloids, I'll let you read about that in the book. That's also good to know. Chapter number 2, there's one other thing in chapter 1, the negative pressure wound therapy. We call these wound vacs, and you're going to see a lot of this in surgery and in hospital care now. So before, we only had secondary intention where the wounds would heal from the inside out. We try to maximize everything. Now we've learned by applying a device, a suction device, on the outside that helps continue to pull the cells, continue to pull the collagen from inside your blood into the tissue. It promotes wound healing a lot better. So you will see these, and we'll show you some pictures at some point in the surgery course when you read up on that. Hyperbaric oxygen in certain hospitals is being used as well, and it can be very beneficial when it is. Chapter 2 discusses hemostasis and coagulation. And basically I've covered 98% of this in hematology already. Now with hemostasis, the word hemostasis of stopping the bleeding that occurs, you also can break it down into either primary hemostasis or secondary hemostasis. And the word primary is that vasoconstriction that we've already talked about that initially happens, and that platelet activation that occurs to stop the bleeding. But secondary hemostasis, I think about those proteins that come from the liver. We make these each and every day. It's involved. If you removed all the platelets out of a patient's body, could they still form a clot? The answer is yes. It may not be a very good clot, but they still could form a clot because they have all these coagulation factors, all these little proteins from the liver. Those are the numbers, 7, 5, 10, 13, 12, 1, 2, you name it. It's a pretty big list. And we divide those coagulation factors into the intrinsic pathway, which are the factors. There's a nice little chart in your book there on figure 2.3 that shows you the intrinsic pathway factors on the left side. That's how I think about it for those of you who are left-handed like me. And this is going to be your heparin arm of therapy, or the test you would do for the APTT, any of those coagulation factors. So the left side, intrinsic pathway, heparin pathway, APTT test. Versus the right-hand people, which is most of you guys, this is the extrinsic pathway. And the PT-INR is what we do. Years ago, we only had the PT test. And the PT range was very different. And it was slightly different. So maybe our PT range here, pro time was, I'll pick a number, 11 to 13 seconds. And maybe in England, it was 12 to 15 seconds. And maybe in Australia, it was 9 to 10 seconds. We all had a different range. And they said, as patients are traveling around the country, around the world, we can't do this. We gotta somehow come together. So what they did was, they've learned that each lab has its own fudge factor value regarding the test. And if you do a calculation with this fudge factor, you now get a new number known as the INR. And the INR is standardized between here and England and Australia, so that way anybody who travels and they're on warfarin, they can get that fixed. The one number I want to stress on the extrinsic pathway is factor 7, and that's the issue. That's where it all begins. There's some factor 7 stuff you'll read about there, but that's probably the most important factor to understand with the extrinsic pathway in the PTINR. And then eventually it all comes together into the common pathway, or the numbers like 10 and 5 and 2, and eventually you get down to 1, which is fibrinogen. And fibrinogen is factor 1, fibrinogen that gets converted to a fiber clot. That's the bottom line of all that. The testing we've already reviewed in the past, platelet counts and bleeding times and PTTs. There's a little bit of a negative feedback in fibrinolysis. Whenever you form a clot in the body, you start to microscopically break that clot up. We need that. That's the balance of life. You don't want to keep that clot there for 30 years. It eventually needs to dissolve. And these are the things on the slide here that allow that to happen, to break it up. The first 3 are the standard anticoagulants we have in our natural body that we've talked about in the past. ATP, antithrombin 3, AT3, protein C, and protein S. We all naturally have those. You'll see on that figure 2.3 where they're working. But the unique thing about AT3 that you should know about a little more in depth is, yes, it inhibits certain factors, but more importantly, heparin accelerates the inhibitory reaction up to 40,000 times. That's why heparin is an anticoagulant, because it's really activating this antithrombin 3 to cause a massive domino effect for it to work much, much more at that anticoagulant. And the bottom 2 are the fibrinolysis things, the plasminogen and the TPA, the clot busters that we think about that help equalize, stabilize the other side of the equation. There's a short paragraph in your book about TEG, T-E-G, which stands for this, thromboelastography. And I've only given you 2 slides that I want you to know about it. Very basically, this is a point-of-care test that you'll see done in the operating room or in the ICU to quickly determine what the patient's bleeding or coagulation status is. If I want to draw their blood and send it to the lab for PTINR, even a stat test is going to take a good 40, 50 minutes to get back. But if I run a TEG, I can get that in like 5 to 10 minutes. So in the OR, it's a really quick way, point-of-care test that's being done. If the patient's bleeding out and you're trying to figure out what's going on, and you'll see this done a lot. So it's a little, if you could all look up here for a second, I'm not going to go into this too much in depth, but they include, it's a little tube, and it's a machine that's got a probe in there, and you add some reagent to it, and then it activates, it tests how long does it take for the clot to form, how quick does the clot to form, you don't have to type this, how quick does it form, how strong is the clot, and then how long does it take for the clot to start breaking down. So it's a quick test that really determines all of that, and it does that by a graph. It gives you a picture. And this first section, this little line here, is called the R, and that's a reaction time for when the clot first starts to form. And then you start to get some more firmness, which is measured by this angle, which I'll show you a picture on the next slide. The angle that changes can mean a little different things. The MA is basically the diameter of the whole thing. That's the maximum amplitude, maximum strength of the clot. And then afterwards, it starts to measure the lysis of the clot as it breaks down. So the first half of this, up to the maximum here, is called coagulation, the clot forming aspect. And then once the clot is fully formed, which is that MA line right there, then the clot starts to break down. And why is that important? Because if you have a patient that's either clotting or bleeding, you can do a TEG, and these are the common findings that I want you to be aware of. The first one here is normal. So you need to know what normal is before you can figure out what any abnormal is. And there's a very short segment in the beginning here, and this is what the normal angle would look like, and that's very cigar shape-ish. This is the normal thing here. If you got a patient whose results comes back like this would tell you that they most likely are on anticoagulants, or they have some sort of possible hemophilia where they're lacking some of the coagulation factors. Same thing as saying they're on anticoagulants. So I have a very long black line here. And then it's a little bit of the angle changes. It's not quite as, it's more narrowed. And the clot that it forms is not as thick as it should be. Some of the platelet blockers, it's going to give you a very narrow picture here. And fibrinolysis can show you this pattern. If patients are more hypercoagulable, so maybe they have factor 5 Leiden or so, right? And now they're forming clots more. They're going to form, this line is very short because they're going to form a clot very quick. sooner than it should, and the cost can be much bigger than it should be. So as you can see the size there. DIC is a mixed state of problems, so they get more of this classic tapering at the bottom. And then stage 2, hypercoagulable state, just don't worry about that. So that's a little bit of visualization of what you'll see, and you will see these. You'll see it in the chart, you'll see it in the computer, you'll see it in the OR. They'll pull it up on the screen for everyone to look at. The nurses know what it is also. Very quickly, the next couple slides here on inherited platelet disorders or acquired platelet disorders. We've already talked about this, like von Willebrand's disease. And one last time, von Willebrand's factor is the glue that holds the platelets together, it sticks them. And if you lack that, then you're going to be more likely to bleed out. That's where that bleeding time test is very helpful. It's done all by machines today. The acquired platelet disorders, so this is you or I, we're all normal, we have normal platelets, but then later in life we get some platelet bleeding issues. What can cause that? Renal failure, extracorporeal oxygenation. So when you're in the operating room and they hook you up to the heart-lung machine, that decreases the platelet functionality, and patients are going to be more likely to bleed post-operatively, and we fix that. We give them more platelets when they need, we give them more factors, we fix those problems. Heparin-induced thrombocytopenia, as I said at the beginning of the class, this is a time to break down into more the type 1 and type 2. And type 1 is very minimal. About 10% of the population has type 1, and if they do get it's very mild, and usually within 96 hours, everything will resolve all on its own. Type 2 is more severe. These are the patients that often can have higher morbidities in the hospital with it. Yes, their platelet count goes down, but the more important problem is hypercoagulable. They get clots, and they get strokes, and they get pulmonary emboli. So you have to stop the heparin if they're on heparin and put them on super heparin, I like to call it, like the argatroban and the different medicines, bivalirudin that you learned about in pharmacology, I'm sure. And then ITP can be very mild or it can be more severe. It's associated with immune complexes. The inherited coagulopathies like hemophilia, there's A, B, and C. The acquired coagulopathies like DIC with sepsis or liver failure. Hypothermia. If you've ever been in the operating room yourself or for operation, you know it's pretty cold in there. You'll notice that the first time you do your rotation when you walk in there, it's pretty chilly, and it's good and it's bad. For patients, it can actually cause them to bleed out more, especially if it's severe hypothermia. The numbers, I'm not sure if they went over this or not in the emergency medicine class, but you do need to know that. And in this book, this is a good time to review that, because I have seen board-like questions regarding this patient has 32 degrees. What is that? Mild, moderate, or severe? What's the effective treatment for those types of patients? So please look at that. And massive transfusions. Another component that's cold that comes out of the refrigerator is blood products. Usually it's 4 degrees centigrade, and if someone gets 5, 6 units, that's going to really drop their temperature quite a bit, which can make them bleed out even more later on. The inherited thrombophilias, we've covered this before, includes factor V Leiden, the antithrombin 3 deficiency, protein C, protein S deficiency, and then acquired thrombophilias like malignancy, they're going to be more likely to form clots, so we may have to put them on some sub-Q heparin in the hospital after their operation. Smoking, we know that's going to do it. We try to get patients to stop smoking, but it's hard to do. Maybe they can do the chews, the gums, maybe they can use some patches, but it affects not only wound healing, but bleeding as well. And then pregnancy, we know, is also hypercoagulable at that time. Some pharmacology. There's a really, really nice chart in your book regarding the pharmacology and the medications, if you're not familiar with what they do and how to monitor them. Which ones are the direct thrombin inhibitors, like bivalirudin and argatroban? Which ones are the direct thrombin inhibitors, dabigatran, that some of them have reversal agents, some of them don't have reversal agents. The factor 10A inhibitors, like apixaban, and all of these different anticoagulants you've covered at some point in your pharmacology course, but this is a good time to just quickly review that here. Procoagulants. So, when patients bleed in the operating room or post-operatively, we always say it's either a medical bleed or it's a surgical bleed. Now, we want to try to fix all surgical bleeds before they leave the operating room. If there's anything we can do to ligate that, to bovie it, different tricks of the trade. Now we have different little chemicals that we can add to seal and flow seal that you'll see used, and a whole bunch of these little Surgicel and Nunit, a whole bunch of names that you'll read about. It's a short paragraph in your book to help you, and we apply these little gauze-soaked components on the bleeders to help them stop in the operating room. That would be more surgical bleeds. We can do sutures around there to tie it off if it's a vessel that's bleeding, or try to use some of the chemicals to stop it more at the surface level. The antifibrinolytics, there's a medicine called Amicar, or transischemic acid. Amicar is something that we use when patients are bleeding more out to help them to stop those fibrinolytic reactions. So sometimes you will see used a little bit. Desmopressin, also called VDABP, can be useful for hemophilia when patients are bleeding there. And then the anticoagulant reversal agents and antidotes. The protamine. Be aware that protamine is what we give to reverse heparin, and the rule is that you give about 1 milligram for every 100 units of heparin that was given. So that's how you would calculate that. You may have to do a calculation on your quiz. If I say a patient was given 20 units of, or 2,000 units of heparin, how much protamine do you want to give for that to reverse it? And then the vitamin K. Vitamin K is going to reverse when the INR is extremely elevated, as well as the fresh frozen plasma that can help there also. So the next chapter, chapter 3, is surgical infectious diseases, and many of this we've covered in different aspects as well. Maybe if you want to have a seat, there's some seats in the back there. I saved them for you there. Thanks. Surgical infections, you'll see in the book, it starts out talking about host defense mechanisms like your skin, your GI tract. You have IgA, is a secretory component in your nasal secretions and your urine to help prevent infections. And then they'll talk a little bit about the microbiological flora. We need some healthy bacteria in our gut to stabilize some of the bad bacteria. And when we don't have enough of that, then the bad bacteria starts to take over the anaerobes. Immunology, we've covered that before. There's the two forms of immunology, the cellular immunity as well as the humoral immunity with the different antibodies. And the microbiology, we've covered also the smallest things, viruses, bacteria, or fungi. There's a nice antimicrobial therapy chart. If you're not exactly sure which antibiotics cover gram-positives, which ones cover gram-negatives, which ones cover both, then this chart will help you. Figure 3.3 in the book to help figure some of that out. So please look at that when you have a chance. Surgical prophylaxis. You'll be hearing a lot throughout this course regarding SSIs, surgical site infections, as these are the things we're homing in on, and we want to cut our infection rates as best as we can. They are the most common nosocomial infection among surgical patients. And with all the research of this, we have been able to prove, evidence-based medicine-wise, that antibiotics should be given before all operations, and there's a time when they should be given. And they should be given 30 to 60 minutes prior to the surgical incision. Overseas, there's a document later on I'll give you, not today, but at some point, that talks about the WHO, the World Health Organization, and they have a time of about 60 minutes. But here in the States, I want you to know everything that when in doubt, questions are going to be coming from here. So even if a surgeon says something and it contradicts here, I'm going to be asking questions that come from the textbook. Occasionally, if there's something unique that the surgeon says that may go against the grain, I'll reinforce it with you, so there won't be any questions on your test. But I can just tell you honestly, most of the test questions are going to come from the book. Some are going to come from the surgeon lectures as well, but that's why I'm saying these numbers are going to be important here to know. Some specific infections, and you'll read their small little paragraphs on each of these. Intra-abdominal infections, your peritonitis that you learned about, when your appendix were to bust in a patient, or colonic diverticula perforates all the way through, then you can start to get these itis infections. Clostridium difficile, trying to, again, keep the good bacteria there to balance out some of this bad bacteria. It can cause colitis and it can be pretty rough. Remember, only oral vancomycin treats C. diff. IV vancomycin does not treat C. diff. Cutaneous abscesses are a surgical issue. Now, if you've not heard this before, cellulitis is a medically treated thing, but Abscess, you must drain. You must drain the abscess. That's a surgery, incision and drainage thing. Antibiotics is not the treatment of choice for an abscess. We give antibiotics. I'm not saying we don't, but you really have to go in there and let the pus pocket out. Otherwise, an antibiotic most of the time is not going to get into where it needs to do, or you have too much residual tissue left over. Necrotizing soft tissue infections are scary. They can come on pretty quick. Your Clostridium perfringens is one of the ones I think about. Sepsis, your gram-negatives are more likely to cause sepsis compared to gram-positives. Urinary tract infections, we've reviewed this before in lab medicine. We try to get these urinary catheters out as soon as we can. We don't want to, if they can get out of bed, they can pee, basically. And even in the ICU, they just have to stand, and we can get the commode right, we can bring it right to them. So we want to try to get out those catheters as soon as we can. Years ago, we would leave catheters in for a week or even longer, and we've learned that those rates go up quite a bit. Question?
What did you say about gram-negative and gram-positive?
You get more gram-negative infections with sepsis. So the gram-negatives are more virulent. They have more, you'll see when you read in the book there, the makeup of the gram-positives and the negatives, but there's a couple gram-positives that have a toxin associated with it, like ASO, anti-streptolysin O, that's a toxin. There's a couple other gram-positives that have toxins, but because of the nature of the gram-negatives, they're more evolutionized and they're more likely to cause sepsis than the gram-positives, generally speaking. Catheters, or any kind of prosthetic. So another example is we would leave in central lines for long periods of time, or Swan-Ganz catheters after operations, and even though when we didn't need them, we just left them in to have more data. And we've learned that the sooner we can get that stuff out, the better they do. Chest tubes and anything else, the sooner the better to get it all out. Post-operative pneumonia. If you remember maybe hearing somewhere, and if you haven't, I'll tell you now, that post-operatively fever can occur in patients. And there are different reasons. There's this mnemonic of the W's. Wind. Does anyone know what wind stands for?
Lungs.
Atelectasis. So atelectasis, there's a whole bunch of W's there, and the first W that can cause fever in the early postoperative phase is wind, which stands for atelectasis. And then there's wind, walking, wound, wonder drug. There's a whole bunch of it. There's a whole bunch of little W's. But for right now, I want you to focus on the first, the most common cause of fever in the early postoperative phase. Early postoperative phase is atelectasis. What is atelectasis? It's when the patients have a lot of pain and they're not breathing as deep as they should, so those alveoli start to collapse. And you'll see these changes on a chest x-ray. It looks almost like an infiltrative pattern. And at some point later on in this course, it's one thing I want to do. I don't know how well you are or are not at looking at chest x-rays and CT scans and MRIs, so I'm going to try to incorporate a couple of these along the way there. And then at the end of that chapter, there's a nice little section on HIV and the CDC for infectious risk factors that I want you to look at. Nutrition. You've had a whole 2 credit hour nutrition course, and that's chapter 4 in the book. And just to highlight a couple things on this is obviously there's protein and carbohydrates and lipids. Protein helps this nitrogen balance, and you'll read in the chapter, if you're unfamiliar, of a positive versus a negative nitrogen balance. You or I, we just have a neutral one. But if you're in one end of the scale, it leads you to be one way versus another way. Carbohydrates are what we ingest daily for the most part, unless you're on a diet, like the ketone diet or Atkins or something where you're taking less carbohydrates. And that's the main source of energy, the glucose. If you choose to not ingest many carbohydrates, you're on one of those diets, then your body will start to break down the fats, which is the reason why people go on those diets. And then the ketone levels start to go up a little bit there. So lipids, we all need a certain amount of lipids. We need it for cells, nerve cells. We need it for our brain. We need it for our heart. We need it for our vasculature. We need it for the cell membranes throughout our body. So the phospholipids that we ingest are part of that. The proteins, just to go back, the very first sentence in that book, I remember reading it, talks about the essential versus non-essential proteins, and that's good to know about. Vitamins, your fat-soluble vitamins are your classic A, D, K. Your water-soluble, I think about, are going to be B and C for the most part. And trace elements. There's a nice little chart in your book that talks about in surgery when patients have poor wound healing, maybe it's a zinc deficiency that we need to investigate. There, you can get a zinc level. Back in the day when I was a phlebotomist when I was in college, I was working at the hospital, and my job was to drive around to nursing homes and to draw patients' blood. And there's this one nursing home that I'll never forget. The medical director there ordered a ton of zinc levels in the early morning on these patients. And yes, we know nursing home patients, they're not getting around as much, maybe they're not getting enough nutrition, and they're getting more ulcers, and he was able to determine that those patients who had low levels, he would give them, significant amounts of zinc to replace that to help them overall. So that's something you think about. Iodine, not related with your thyroid as well. Copper in there, fluorine with your dental caries, and iron with the anemias that we've talked about in the past, also selenium with cardiomyopathies. Your electrolytes in this chapter, you all know this very well. Your sodium is normally 136 to 146. You understand hyponatremia, you understand hypernatremia. If you don't, this is a great time to just look at that. Potassium normally is 3.5 to 5.0. Again, you understand hypokalemia, maybe it's diuretic induced, maybe it's pathology induced. Hyperkalemia is a true emergency. You can start to get those EKG changes of peak T waves and prolongation of the PR interval and widening of the QRS that leads to ventricular dysrhythmias there. Emergency medicine, you've probably gone over all the different ways to treat hyperkalemia. Just to quickly review, your albuterol at very high doses. You can hit them with high-dose Lasix. If 40 doesn't work, hit them with 80. If 80 doesn't work, hit them with 160. You can give them Kayexalate, but Kayexalate takes hours. Whether you give it orally or rectally, it's going to take a while to kick in. You can do the insulin and glucose thing, a half amp of D50 and 10 units of regular insulin. That helps push the potassium into the red blood cells to lower that serum potassium. And then, if all that doesn't fail you, you dialyze the patient to bring that down into the emergency. Calcium. When I see the word calcium, I think about the parathyroid gland. So you don't have to memorize two different things. If you understand parathyroids, you understand calcium. Hyperparathyroidism is the same as hypercalcemia. Hypoparathyroidism is the same as hypocalcemia. So look at that if needed in the book. Magnesium is an important concept that we'll replace in the operating room. We'll see this sometimes when patients have an ileus. So one of the more classic times, if they have an ileus, you're going to check their potassium, we're going to check their magnesium level, and we'll give them some of that extra magnesium and potassium to tank them up a little bit, as we say, because it does help their ileus. So a small bowel ileus, it's a nice treatment to understand there. And magnesium, for torsades and some of the other conditions there. The hypermagnesemia is when you're most likely going to see that with renal failure. So that you'll see that's the first line in that regarding hypermagnesemia. And phosphorus is not as important. Sometimes it's related more with nutrition, enteral or parenteral, which is going to be my last, I think, 2 slides coming up here. Now, nutrition assessment. This is important. There are nutritionalists who go to school to get degrees on that. You just had a 2-credit-hour course, but there's a lot more to it. It's pretty interesting. And pharmacists nowadays are doing a lot of this in the ICU, where they're calculating out the enteral and parenteral nutrition that patients need. Enteral means, oral. We're all used to eating oral. Our GI tract is set up for oral food, and we're just used to it for however many years old we are. But if patients cannot ingest it orally, maybe they need just a little bit for a day or two, then we'll put a small NG tube down or a Dopphoff tube, leave that in for a little while. It can be post-pyloric nasoenteric tube. Sometimes it's in the stomach, but if you can push it down a little bit farther into the duodenum, then that's a better place. That way they don't get the effect of feeling it so much, or some of the regurgitation that they may have. And if a patient is going to have it in for a longer period of time, then we're going to think of more of the PEG tube or the PEG tube, which is a percutaneous endoscopic gastrostomy tube or jejunostomy tube, where literally, Dr. Smith at some point, we didn't get to it last year, but I asked her, I said, as PAs, we deal a lot with these PEG tubes and that, and it'd be great to show you a video and talk a little bit about 2 of the more common procedures that surgeons do when they're consulted after complications of operating room things like the PEG tube or tracheostomy as well. So later on, I'll try to get you a little more information about that. Enteral nutrition has a lower incidence of infections and complications. You'll read about that. And parenteral, when someone cannot take enteral at all, then we have to give it to them through an IV, and that's called parenteral. We call that TPN, total parenteral nutrition. Hopefully you learned a little bit about that in your nutrition class. There's this rule of sevens that I think about, and there's only like 2 sentences about it in your book, but it's a general rule of thumb where you're not going to start TPN unless the patient is going to be without nutrition for 7 days. Generally, rule of thumb. It sounds like a long number, right? But we have some stores in us that we can get some nutrition, and sometimes we can give a little NG here or there. But if it's going to be, if you're, some say 5 days, but most people will say 7 days. And then the other side of the coin with the number 7 is we want to be able to keep that in for at least 7 days. If you know you're not going to be keeping this in for at least a week, some people have this in for months and months long term, that nutrition, then it's not worth doing that operation for that. And like I said, don't worry about the actual how, what it is, of how to do it. And we're not going to be focusing a lot of that in this course, of all the different operations, and that it's give you the core concepts of what to do when you're in the operating room to help patients with that. So my last couple of things here, and then we'll take a break, but I'll tell you before we get started with lab is, number 1, on Monday, ExamSoft will be the quiz style. It will be a 30-question quiz to include information from your book chapters 1 through 4, this week 1 handouts, and today's lecture. So you're kind of got a little bit of a bonus for this first quiz because the 4 hours in the afternoon today, you're not going to be having added lectures. For the rest of this quarter, you will be having 4 more hours of lectures, so that's going to add a little bit more to that. So wanted to tell you about that. And the other thing to tell you is regarding reflection. So one of the concepts in higher education is this concept of reflection. And I thought it'd be a great way. We've been in, I know some PA programs are doing this now, and this is something in our doctorate that McIntyre and I are in that is using a little bit more for this, and we've been doing it now for a good 6 months. And we've noticed that it actually helps. It sounds weird, but it helps. And it's a way to keep you better engaged. So our webinars that we have to do for our doctorate program, they notice that sometimes people are on the Facebook or on their phones or texting, you know, just like anyone else in the real world does. I do it too. So they found this way of linking the reflection to keep us better engaged. And throughout your lectures for the rest of this quarter on the Fridays here, we're going to give you a reflection at the end to see what you remember from the lectures you learned. This is not an open book test or anything like that, but it's also how you feel about certain things. How do you currently feel? I'm going to hand out, it's a one-page little questionnaire. I'm going to hand it out now. How do you feel about certain things? How do you feel now about the first day of your rotation of surgery? Maybe it's good, maybe it's bad. Do you have any experiences with surgery? So you're going to see these little questions here. If everyone can just stay quiet for like just the next 10 minutes, I'm going to hand this out. You're going to sign it and fill this out. When you're done, I'll allow you to take so it's 10:20 now, or 10 after 10. It'll only take you 10 minutes or less to finish this out. And then you can take a short break out there and come back at 10:30 to get started with the